Thank you very much. First, I would like to thank the organizers and Professor Ednik for a very kind introduction. It's a pleasure to be here. The title of my talk is Autoinflammatory Diseases with Osteoarticular Involvement. And I would like to somehow focus in my presentation on monogenic causes of arthritis and monogenic causes of osteitis. In pediatric rheumatology, we do not have a monogenic model of juvenile idiopathic arthritis. If we would have a model, genetic model of juvenile idiopathic arthritis, we would kind of be able to research the pathogenesis of disease more thoroughly. But from this monogenic arthritis and monogenic osteitis, we can somehow look what are the pathogenic mechanisms that are causing arthritis and osteitis in our patients. So I would like to just start with the data from our National Inborn Errors Registry, which we started more than 15 years ago. And we, this is going back. Do we have also a pointer? No. Do we have a pointer? No. Okay. So in these patients, we said, okay, so let's search for autoimmune and autoinflammatory manifestations, all non-infectious, and we identified nearly 30% of patients with inborn errors of immunity that had some autoimmune, autoinflammatory manifestations. After our study was published, the French group published larger cohort study, exactly the same, investigating non-infectious complications, and they identified that 12% of those patients that had autoimmune manifestations, 12% had some underlying rheumatological disease. And if we look a little bit more in depth, what are the kind of monogenic autoinflammatory diseases or monogenic diseases that are causing joint involvement? In this table, I would like to show and highlight the inflammasomopathies. I will talk about inflammasomopathies also in my later presentation. So cryopyrin-associated periodic syndrome, or CAPS. Familial Mediterranean fever will be covered by my colleague from Israel, Ben Zvi. We will talk also on TRAPS and mevalonate kinase deficiency. There will not be time to cover PAPA syndrome. But there are also some other monogenic diseases that are causing arthritis. Blau syndrome with granulomatous inflammation. Chronic granulomatous disease is more regarded as an inborn error of immunity. And we have a new group of diseases, interferonopathies, SAVI and COPA syndrome, that also can cause arthritis with a different mechanism. And one of the relopathies, haploinsufficiency of A20, can also, which is, let's say, monogenic Behçet syndrome, haploinsufficiency of A20 can also cause arthritis. I have a few slides on inflammasomopathies. I would just like to highlight that inflammasomes are big factories that are producing inflammation in our cells. So we have different factories and we have different inflammasome factories within the cells. Most studied and most well known is NLRP3 inflammasome. You must know that these factories are working like I sometimes compare with like a hunting dog on a leash. They are ready to attack, and they have a severe autorepressive mechanisms that they would not just attacking. If this leash is broken, they would have kind of a excessive inflammasome production of cytokines. This is the mechanism of NLRP3 inflammasome. I do not have a pointer, but I would just like to highlight. So this is the normal state. Either intracellular or extracellular signals would somehow stop this autorepressive mechanism. Inflammasome would go into the production of inflammation. And in mutation of NLRP3, like in CAPS syndrome, we would have constitutive hypersecretion of inflammasomes without any ligand needed. It would be just, you can imagine, hunting dog without a leash, running away. Why are these inflammasomopathies so important for bone and bone hemostasis and diseases? It's somehow interesting that NLRP3 inflammasome is expressed in osteoblasts, in osteoclasts, and chondrocytes, which is pretty important information. And if you look at monogenic diseases, you might have either osteolysis or production of bones. So on both sides, it's a complex kind of equilibrium between dysregulated inflammasome and pathological bone, either accrual or loss. So let me first focus on CINCA, or the most severe phenotype of CAPS syndrome. It can cause arthritis, arthralgia, and very range of spectrum of skeletal abnormalities, such as patellar and long bone overgrowth, particularly epiphyseal overgrowth and calcification, deformities, bone erosion, and osteolytic lesions. On this slide, on the right-hand side, you can see arthritis in a neonate with CINCA syndrome. So definitely you see that with defective inflammasome, you can get a full-blown arthritis in a neonate. On the left side is a urticarial rash linked with CINCA syndrome. This is a patient who had a long-term CINCA syndrome that was not treated. You can see the left leg that doesn't look so deformed as the right leg, where you can see significant patellar overgrowth, significant epiphyseal overgrowth also in the ankle area. And this is a very nice study where they investigated sequential X-ray images in patients with the CINCA-NOMID syndrome. You can see on the left-hand side, there is some epiphyseal overgrowth. On the second picture, some calcification in metaphysis. And on the third slide, significant patellar overgrowth. We do not want to see this in clinical practice. This is kind of a before canakinumab. And the same patient, you can see also the progress of ankle involvement. And at the last picture on the right-hand side, you can see actually, the end-stage disease with ankylosis, with overgrowth, and patient is severely disabled. So this is one of our patients with CINCA, who was diagnosed more than 10 years ago. One of the first patients was interesting story. It was that we first sent the genetics. We didn't have genetic testing at that time at our center. We sent to another center, recognized center, but they said that it is negative, but the disease course was pretty typical. We sent to NIH and was confirmed as a CINCA patient. He was treated with canakinumab from the very early stage when the canakinumab was available. But what I would like to highlight, he has recurrent episodes of coccitis. So we do not see epiphyseal overgrowth because patient is well controlled, but we do see some musculoskeletal syndromes. And with, let's say, better treatment, we will see this kind of patients. And now, after several years, he has leg length discrepancy of 3 centimeters. So recurrent coccitis with leg length discrepancy in a patient with CINCA syndrome. I will now leave inflammasomopathies, and I will move to granulomatous inflammation. So granulomatous inflammation as a cause of arthritis. Blau syndrome is regarded as an early onset sarcoidosis. It's a mutation on NOT2 gene, and you can see this significant arthritis. It is referred as a boggy arthritis because you have granulomatous inflammation. It's not just inflammasome, just cytokines, but it's kind of a tissue infiltration, granulomatous infiltration. What is characteristics of Blau syndrome? Non-painful arthritis. They have significant arthritis, but patients are not complaining of any pain. They have the same mechanisms also in tenosynovial tissue. You know that synovial lining and tenosynovial lining are exactly the same histologically. And these patients have granulomatous inflammation, also in tenosynovitis. They have the same mechanisms causing uveitis, and they can develop also rash. A nice study that investigated family members with untreated Blau syndrome. Because of tenosynovitis, you can see flexion contractures in PIP joints. So non-painful flexion contractures in PIP joints. If you have patient in your clinical practice, non-symmetric, you can see certain fingers, definitely these kind of patients need to be investigated for Blau syndrome. And the X-ray images, you can see on the X-rays the periarticular osteoporosis, the sausage digits because of the tenosynovitis, and on the MRI image you can see pointing with arrow tenosynovitis. So these are the granulomatous inflammation as a cause of arthritis. Now move to the third group of diseases. Interferonopathies. You know that interferonopathies are now very popular with COVID-19 and a signaling of viral nucleic acid, but they sense also our nucleic acid. When the nucleic acid gets degraded, this intrasolic receptor, this mechanism would recognize. So I will not go, MDA5 you might recognize from JDM, anti-MDA5 antibodies. This is receptor, also cytosolic receptor for nucleic acid center, but I will highlight on STING, protein that is causing the SAVI, and I will not go into more detail for interferonopathies. Interferonopathies are more known for their neurological involvement and other symptoms. JAK inhibitors are not working for neurological manifestations, but are working for all other manifestations of interferonopathies. We have one severe patient with Aicardi-Goutier treated with baricitinib, but I would like to focus on SAVI and COPA syndrome as a cause of arthritis. So SAVI is caused by gain-of-function mutation. It's a protein that is important for interferon signaling at the level of endoplasmic reticulum. Typical clinical features with skin rash, interstitial lung involvement, vasculopathy. I will not focus on these other manifestations. I will focus on arthritis, which is rare in SAVI, but can be present in approximately 30% of patients. French group just recently showed this data from their registry that SAVI patients presented arthritis with 30%. From this paper, what is even more interesting, if you remember in Euler in Madrid, they first reported COPA syndrome. COPA syndrome is somehow similar mechanism as a SAVI syndrome, but is not at the endoplasmic level, but at the communication between Golgi apparatus and endoplasmic. So COPA syndrome is kind of a variant of SAVI, but has much more frequent arthritis. So 70% of COPA syndrome patients can cause arthritis, and I thought that it is somehow interesting to put these groups of diseases together to show that also interferonopathies can be a cause of arthritis, and these arthritis manifestations can be treated with JAK inhibitors. It is difficult to measure interferon alpha. STAT1 phosphorylation can be done on flow cytometer. Probably it is easier to just check interferon signature with RNA sequencing in this group of diseases. So now in the second part of my talk, I would like to focus on monogenic diseases that are more kind of causing the bone inflammation. Majeed syndrome is a monogenic form of CRMO. So chronic recurrent multifocal osteomyelitis. It has similar clinical presentation. DIRA syndrome I will present. So these are one of the typical monogenic bone disorders. I already talked about chinca or CUPS. CUPS can cause both joint and bone involvement, and Mirage is a very rare syndrome. We have one patient that underwent autologous bone marrow transplantation, but I do not have time to focus a little bit more. So I already said that these inflammasome and bone diseases are kind of closely linked. The common clinical denominator for these patients is chronic non-infectious osteomyelitis. This is what we see in the clinic when we evaluate patients, no matter what is the underlying cause. So one of our patient with CRMO, you can see the involvement in the humeral area, the hip area, knee, so these are typical weight-bearing joints. This is a really Friday afternoon consult. I was consulted at the infectious disease department. They said that they have a very unusual osteomyelitis. So I was called because of this picture on MRI. I came to see the patient. I reviewed the MRI images. This MRI was not available on Friday afternoon, but later because we performed the whole body MRI. This is just to show, because this is a clinical question for you. And when I came to the infectious disease department, I saw this patient with this clinical presentation. Does anybody knows? This is a kind of a osteomyelitis and this skin involvement. Sappho syndrome, but you are not allowed to answer. Okay, yes, Sappho syndrome, which is kind of a diagnosis that can be really done. When you once see, I would say, this type of acne, you would recognize Sappho syndrome. So it is a variant of CRMO linked with spondyloarthritis. It's acronym for synovitis, acne pustulosis, hyperostosis, and osteitis. Just to show the treatment for CRMO, different treatments are employed. This is a study that we performed together with colleagues from Florence, Lyon, and Lausanne. We somehow compared our clinical experiences. Usually we first use non-steroidals. Some patients would respond to non-steroidals. Then we use methotrexate or biphosphonate if the patient has osteoporosis. For refractory patients, we would use anti-TNF. But I used CRMO more to somehow introduce the monogenic syndrome of osteitis, which is a Majeed syndrome. Majeed syndrome is actually a loss of function mutation in the lipin-2 and is causing low intracellular cholesterol. And this low cellular cholesterol leads to NLRP3 inflammasome activation, which is kind of a nice interplay of metabolic disorder causing inflammation. And therapy with IL-1 blockade is pretty effective. In Majeed syndrome, on the right-hand side, you can see that these patients have like macrophages that have an inflammatory phenotype. They have more active osteoclides, and they are producing more TNF-alpha and IL-1 beta, leading to this osteitis. I will briefly touch this syndrome, which is a deficiency of our natural anakinra in our body. If we are lacking our natural anakinra, IL-1 beta will go crazy and will be unopposed in our body. These patients present early in life. You can see this very severe pustular dermatitis in a patient with DIRA syndrome that leads to severe systemic inflammation, skin and bone involvement, and anti-IL-1 blockade is very effective in this group of patients. You can see the epiphyseal bony overgrowth, and they have these widened ribs, patients with DIRA syndrome. So at the end, I would like to conclude that these monogenic joint and bone disorders really kind of provide our insight in the study of pathogenesis of inflammation. I didn't focus on immuno-osseous dysplasias, like, for example, cartilage hair hypoplasia, which can also, for example, cause this non-inflammatory immuno-osseous dysplasias. But I did show some inflammasome, autoinflammation mechanisms. I showed granulomatous inflammation and some bone metabolic disorders that can cause osteitis and arthritis. In this group of diseases, we must be aware that bone and joint disorders might not be the only clinical problem, and for some of those, for chinca, for TRAPS, I will show in my next presentation the other clinical manifestations. And knowing the disease pathogenesis sometimes can lead us to more targeted treatments, and that's why I kind of really always try to pursue and search for some underlying mechanisms with an underlying monogenic cause or functional mechanism that is causing the disease. I would like to thank my colleagues that are we are a team that are working together in this group of diseases, and I would like to invite you next year for the Autoimmunity Congress in Ljubljana. Thank you very much.